Roman. He is not here today, and Dr. Ramirez would like to just begin. So I will give him the podium.
Thank you. Yes, since the chairman is not here, we're going to start on time. Okay, then the idea this morning is to give you an overview of travel medicine. As you know, we have started with a travel medicine clinic in the Department of Medicine. And what I'm going to discuss is, this is the outline of the presentation, a little bit of some principles, general principles of travel medicine. What is the pre-travel consultation, travel consultation, what happened with the returning traveler, and then just a couple of slides of this clinic that we have now, that we changed our name from WINS, that was in the past, now to the 550 clinic here in the ambulatory care building. Just to also clarify that the travel medicine clinic that we started in the Department of Medicine is not new. It has been and no, Dr. McKinney Paul is here. He has run the travel clinic in the School of Public Health during the year, but now we just move it, as we were discussing. This is the travel medicine, because we just moved 3 times in the last couple of months. Then, as principles of travel medicine, and of course this is going to be for mostly for international travelers, and looking at what happened in the U.S., there are 61 million trips of U.S. citizens that are going to be at least one night outside. And when you look at what happened worldwide, this is a lot of people that are traveling international. And every time that this data, the number keep increasing and increasing. And the issue is, why do we need medical advice for international travelers? Well, because as you travel, there is a lot of risk associated with travel. Who is going to develop illness? More than 50% of travelers are going to develop some illness related to travel. Approximately 10% of travelers, when they return, are going to look for some form of medical advice. And there is even the possibility of death during international travel. And the numbers are here. Then, because of all this, there's a lot of need, and this is really travel medicine. Is a new area in medicine. Started in particular countries, now is expanding. This almost any big city that you have international travelers, you have your travel medicine. And in the area of infectious diseases, this is becoming a subspecialty inside of infectious diseases. The same way that we have HIV medicine or other forms of subspecialties, now we're having travel medicine. The medical advice is based on some characteristics of the traveler and some characteristics of the trip. And what we're doing in the clinic is prevention or treatment of infectious diseases. We're looking at personal health, because the majority of travelers have some medical conditions. We are looking at advice regarding environmental risks, and then some issues related to personal safety. In our clinic, we are following the United States guidelines. There are several guidelines for travel medicine. And in the United States, usually it's the CDC, that is for vaccinations and advice, that is usually based on the advice given to the Center for Disease Control through the ACIP, the Advisory Committee on Immunization Practices. Then we also have the FDA, that will be the regulatory agency. And then we have also medical societies, such as the Infectious Disease Society of America. And then you have all these different guidelines in the U.S. There are also, this will be then the U.S. guidelines, but there are also international guidelines. The World Health Organization, the International Society for Infectious Diseases, and there's also an International Society for Travel Medicine. And then we can go into different countries, that different countries are going to have the local national guidelines for travel medicine. The issue that I want to bring with this is that there are conflicting recommendations in all these guidelines, and the conflicting recommendations, as I mentioned, there are multiple guidelines. This is a new medical practice. And as everything in medicine, we would like to believe that we're doing everything based on evidence. But in reality, there is minimal evidence in travel medicine, and there's a lot of expert-based opinion in travel medicine. There is also the concept that the perception of risk is different on different cultural settings. And this then we ended with different recommendations. And I think that this is important because the international traveler is going to come to clinic, we are going to give an advice, and then the person is going to go to the internet and is going to figure out that there are different advices when you go and move around, or you can look at another physician that's going to give you a different advice. Then, now, for instance, in vaccination, you don't even need to go outside the United States. We discussed that in vaccination, sometimes the Advisory Committee for Immunization Practices has a recommendation that the CDC adopt, but it's different from the FDA. Then you have the same vaccine in the United States, where the FDA recommends one application and the CDC recommends a different application. Then you may not need to travel outside the United States to have conflicted recommendations. Just to put this in a perspective, for instance, this will be a map from the CDC of malaria epidemiology, chloroquine resistance, and this is the area in Africa and Asia. But the point that I want to bring is that if you travel to the same region in India and you travel from the United States, then the traveler is going to follow the US guidelines. You travel for Germany, you're going to follow the guidelines from the German government, and for the US, you're going to get prophylaxis for malaria. But from Germany, you're not going to get prophylaxis. You're going to get self-treatment for malaria. Now, everybody's looking at the same data, everybody's looking at the same information, and the experts have completely different recommendations from different countries. This is an evolving team of travel medicine. And another thing that is evolving, of course, is that we are advising the traveler regarding the risk of local infectious diseases. Then again, what happened 2 months ago, we have a new outbreak, a new epidemic, or a new development of resistance, and then this is a very dynamic recommendation. This is why when you go to clinic, the members of the clinics are going to be constantly looking at the computer to figure out what are the recommendations from yesterday for a particular advice. Then, from the traveler perspective, we are going to look at medical conditions, diabetes, CHF, COPD, the immune status, is the person immunocompromised or not. We know that there's a lot of vaccines. When you have a live vaccine, it's going to be contraindicated in immunocompromised patients, but at the same time, immunocompromised patients may be at higher risk of developing certain infections. Pregnancy is going to be important, and allergies. There's a lot of vaccines that still are produced in eggs. Then you have egg allergy, may be an issue. Regarding the trip, what is going to be the itinerary? It's not just you go to a particular country. What are going to be the areas in the particular country, for how long you're going to be there, what activities are you going to have in this particular country? Is this a business trip or is it a biking trip that you're going to be doing? And then, of course, accommodations. Are you going to be in a 5-star hotel with air conditioner, or you're going to be camping? Okay, all these are factors that are going to make that this is going to be always an individualized medical advice. Okay, another thing that we notice is that I put here ranking according to risk. Sometimes, because you may go to, we notice, but I'm also surprised, you go to the travel medicine, and then you have all this advice. And you want to follow all this advice, this is going to be more than $1,000. And the problem is that all these lists of vaccines and things that you have to do, most of the time, they're not covered by your insurance. Because they consider that you plan to go and have fun in the Philippines. It's not a matter of, no, the insurance is not supposed to cover. Then there's a lot of issues with travel medicine and financial problems with some of the travelers. Then what do we do when any one of you that decided to go and have an international trip is coming to the clinic? Then this will be the pre-travel consultation. And this is what takes usually most of the time. And I may say that it's everything about prevention, but it's going to be prevention through vaccines. It's going to be some infectious diseases that are non-vaccine preventable. We are going to look at some medical conditions and then general education. Then when we look at vaccine preventable infectious diseases, usually there are three types of vaccines that we are looking in travel medicine. One is the vaccines that are going to be recommended for anyone just to be healthy in the United States. These will be the traditional vaccines. Then when you plan to go and do your international travel, we are going to check if you are up to date with the vaccine that you're supposed to have. Then based on the location of travel, there are some specific vaccines. And then there's also a third group of vaccines that will be the ones that will be mandatory in some countries. This is a superposition here, but for routine preventive health, we are going to be talking MRI, Tdap, varicella, pneumococcal, and influenza. Vaccines according to risk, hepatitis A, B, typhoid, polio, Japanese encephalitis, rabies, and vaccines that sometimes are required for some particular trips, that will be the meningococcal, meningitis, and the yellow fever vaccine. Then briefly, to give you an overview of this topic, then measles, mumps, rubella, and we are looking here at adults, assuming that, even though in the travel medicine clinic, sometimes the family arrives, and we have to be looking at vaccines in pediatrics and adults. Then if there is no evidence of immunity, then we will recommend for the international traveler to receive the MMR. Looking at Tdap, tetanus, diphtheria, and pertussis, again, this is another thing that it doesn't matter if you're going to travel or not, but if you come to the clinic and you're going to travel and for the last 10 years you don't have a booster for your tetanus vaccine, then we discussed that because these pertussis, even in the United States, then one dose of the vaccine has to be the tetanus toxoid, reduced diphtheria toxoid, and acellular pertussis, then you're going to get a dose of the Tdap. And this will be another vaccine that to prevent varicella in adults. Then if there is no immunity to varicella, you also will get your varicella vaccine. Again, we are discussing things that this is a combination of the travel medicine plus the vaccine clinic. Because even if you come into the vaccine clinic to get your regular immunizations, just as a healthy adult, you are going to be getting all this. Then the varicella, again, a live attenuated vaccine, meaning that if the person is immunocompromised, it's not going to be indicated. Influenza, another one that we tend to get every year. Then winter, circulated in the northern hemisphere, winter in the southern hemisphere, and then year-round in the tropics. But we know that here's December, February. Well, it's even this week, and we are still seeing hospitalized patients with severe influenza in different hospitals in Louisville. Then it's not a matter of influenza. All of a sudden, it's the end of February, and we don't have to be considered influenza. As a matter of fact, our CDC study of influenza, we are extending the study because we thought that the influenza A decreased in March, and then by the end of March, we have a peak of influenza B, and we have a lot of hospitalizations due to influenza B. The problem is that, let's say it's July, and you come to the clinic, and you plan to travel south, and there is influenza here, but in July, we don't have usually influenza vaccine to give you when you plan to travel south. Then you're going to get the advice that you are going to go to Australia. This is the influenza season, but essentially, we hope that if you received the influenza the year before, you may have some protection, even though we know that antibody levels are going to keep decreasing. And the other thing is that influenza is also year-round if you take a cruise. Even if you take a cruise to Antarctica, because there's no mosquitoes, there's not influenza in Antarctica, well, it doesn't matter, because in a cruise you get a sample of all the population worldwide. Then cruises are, everything counts all around the year, okay? This will be, and then we have the influenza vaccine and the pneumococcal vaccine, another vaccine that regardless if you're going to travel or not, if you come to our vaccine clinic, you still are going to get the influenza vaccine. Then this will be the vaccines that if you plan to do an international travel and you come to clinic, we will give you but we will give you also this even if you come to our vaccine clinic without traveling. Whereas we have recently a person that came to the travel medicine clinic because he was having to Montana. Then okay, fine, we'll give you the vaccines. We still have some vaccines for you even if you go outside of Kentucky, okay? Even if you go to Indiana, we can give you some vaccines. Then moving to vaccines that you're going to be if you travel abroad. And probably one of the most common ones is going to be hepatitis A, because as you see here in the map, unless you travel from the United States to Canada or someplace in Europe or Australia, then essentially any country that you're going to hit, hepatitis A is going to be an issue. Then it's a viral inactivated vaccine. It's 2 doses for hepatitis A, but we know that you give 1 dose of hepatitis A, at least you're going to get antibodies, enough antibodies that are going to be protected as long as the vaccine is 2 weeks before traveling. Then if you are going to send any one of your patients to the clinic, we need to see a person 4 to 6 weeks before, at least 4 to 6 weeks before the traveling, because it's going to be certain vaccines that, of course, you give the vaccine, you need to have time to develop antibodies. The second dose of the vaccine, a couple of months down the road, 6 months, well, we give you the second dose when you return from the travel, and then you are going to be protected nothing is for the rest of your life, but it's going to be long time protection with the hepatitis A vaccine. Now, there's an issue, for instance, if you have travelers that live for a prolonged period of time or were born in endemic regions. Because we have essentially we have a person that was born in any one of these countries and is, for the last 10 years he's living in Louisville and now is planning to travel. Well, the issue is most likely you are going to be immune because most likely you will spend several years in any one of these countries. You already have hepatitis A, either with jaundice or without jaundice. But then this is the issue. You get the vaccine or you get immunoglobulins to check the antibody levels before the vaccination. Hepatitis B, another one that you're going to get out of the United States. Of course, that for any one of us, healthcare workers, everybody's vaccinated and we all have antibodies and we've been checking our antibodies, then it's not an issue. But we know that for any traveler, because people say, well, hepatitis B, well, it's sexual contact, it's blood, it's needles, it's not for me. Well, yeah, it's not for any one of us until you travel and you have an accident. Then, essentially, you're going to be in contact with healthcare in any one of these countries. And once you are in contact with healthcare, you are at high risk for hepatitis B. And when we mentioned initially that there is death among international travelers, the cause of death is usually not an infectious disease because, you will know that you may die of malaria, but it's going to be accidents. It's going to be then motor vehicle accidents. And usually you're going to end in the hospital and you're going to get needles. And in most of these countries, 75% of the needles are reusable. They're just sterilized and then used again. Then, if you're going to be contaminated medical equipment or blood transfusion, then it's better to have your full series of hepatitis B before you travel. In the case of typhoid fever, there are multiple areas with typhoid fever. There's the live attenuated oral vaccine that we're using in the clinic. We know that typhoid fever may be caused by Salmonella typhi or Salmonella paratyphi. The typhoid fever vaccine doesn't cover Salmonella paratyphi. It's only for Salmonella typhi, and there's only 75% effectiveness with the vaccine. Some people say, well, I'm just going to take care of myself. The issue with typhoid that is emerging is the problem of Salmonella typhi that is multi-drug resistant to, at this point, resistant to quinolones and resistant to all oral antibiotics. Then the problem there is if you get typhoid fever, then the only way to treat it is going to be with ceftriaxone. And the problem is not so much the ceftriaxone, it's the needle that is associated with ceftriaxone use. Then you have to be in contact with healthcare, have needles, and get ceftriaxone. then is an important vaccine. As I mentioned during this presentation, I'm going to mention a couple of vignettes, clinical vignettes, and this is going to be the first one. 56-year-old white male, scheduled to the travel clinic for the pre-travel evaluation. The patient will have a full history, not any medical problems, no medical problems, any medication, no medications. The person is going to travel to an area with typhoid fever, explain the vaccine, the person is given the vaccine. It's an oral, live attenuated vaccine. The patient leaves the clinic, and then we will start reviewing the medical records. Just happened to be that the person had a kidney transplant, and he's on immunosuppressive medication. Go and figure. Then I'm discussing this with Ruth Carrico, and we said, well, first thing that we're doing, we call the lawyer. No, call the patient. We call the patient to see how the patient is doing. He's still doing fine. Then what will be the management? Well, we look at it's good that the oral typhoid fever vaccine is that one strain that is antibiotic susceptible. Then the patient was treated with ciprofloxacin. Then there was an early treatment of typhoid fever in an immunocompromised patient. He did fine, responded to antibiotics, but essentially it's shocking to us to figure out that a good history and physical, and for some patients, this is a kidney transplant. He didn't have any medical problems, and he didn't have any. Then, teaching point here that we have to, before giving any live vaccine, we need to emphasize if the person happens to be immunocompromised, and ask the question in different ways. Polio, we know that there are only 3 countries now that the polio. Now here we have Pakistan, Afghanistan, Nigeria. Then you travel to these areas, you're going to get a booster of polio. And there has been some small outbreaks of paralytic polio a couple of years ago in Haiti, Dominican Republic. Seems to be that given you give the live attenuated oral virus, the virus has been circulating in the population and been able to reverse to more virulent virus. There have been some cases reported of polio due to essentially to the vaccine. And this will be the situation for polio. Japanese encephalitis, this is the area of Japanese encephalitis. You have to be in the countryside because the mosquito is breeding the rice fields, the reservoirs are the pigs, and this is going to be, again, it's a viral encephalitis, but the vaccine is effective. And then rabies, that is another consideration, see all the areas. Now, the vaccine is going to be only indicated if you are a veterinary person, or you're going to work with monkeys someplace, or you're going to do, bats are going to be in contact with you because you're going to be exploring caves in some area. Then we say, well, rabies is never for me. But what is interesting is that rabies, we need to get the advice of dog avoidance for anyone in any place here. And mostly for the business traveler. Every time that I read about the business traveler, I see any one of us traveling to a meeting international. I say the business traveler, you're in a 5-star hotel or some hotel, but then you decide to go and jog in the street before the meeting or after the meeting. This is what you get to get by the dog. Then the idea is you are jogging, you see a dog, you turn, okay? But this is what I've been doing lately. Okay, for meningococcal meningitis, there is the meningitis bell. You travel to this area. Initially was, the epidemic season of meningococcal meningitis was December to June during the dry season. But again, as the climate change, and now there's not such a thing of season for any particular organism. Now everything is becoming year-round. For meningitis. It is a quadrant meningococcal vaccine, the same one that we will recommend in the US for patient risk. And again, these are the serotypes A, C, Y, W135, and we know that the problem here is that one of the most common serotypes causing meningococcal meningitis, serotype B, that is not present in any vaccine, then still is an issue. This will be a vaccine that is mandate. If you go to Mecca for pilgrims, then this will be a vaccine that Saudi Arabia will mandate. Of course, meningococcal meningitis, when you go to this area, the issue is, are you going to be in close contact with people? Because you're going to get meningococcal from contact with people. And of course, you go to make up one of these picnics, it's going to be a lot of close contact of people. This is why there's a lot of vaccines that are going to be important there. The meningococcal meningitis, the pneumococcal vaccine, several other vaccines. Okay, going to yellow fever, this is a classical one that is a lot of countries that are going to require that you have yellow fever, either otherwise you cannot get into the country. It's a live attenuated viral strain, and the problem with the yellow fever vaccine is some of the toxicity of the yellow fever vaccine. Then there is always a debate because the neurological disease is a form of encephalitis, Guillain-Barré, reversible, and then the viscerotropic disease that is almost like the real yellow fever. But to me, you say, well, it looks like yellow fever. Well, this is a live attenuated vaccine that once we give the live attenuated vaccine, the person, the virus is going to multiply and almost everybody is going to get viremia. Then the issue is that it's rare, but some patients are going to get the real yellow fever. And you can get, the liver, the kidney, you can get the multi-organ failure. And also, I discussed this in our prior presentation of vaccine. This is why live vaccines are so good, and they have almost lifelong protection. Because when you are getting a regular vaccine that is not live, the only amount of antigen that you get is the one that is in the vaccine. That's it. When you get a live vaccine, we inject you something live, these virus multiply, and then you get more and more antigens than just with a dead vaccine. The problem is that with these live vaccines, they start multiplying. We count that the immune system is going to hold it there. This immune system is abnormal, then you can get disseminated disease. Well, and this is why these problems with the yellow fever vaccines tend to be, of course, this vaccine is not indicated you are immunocompromised because, again, it's a live attenuated vaccine. But if you are more than 50, more than 60, more than 70, and we know that your immune system starts decreasing, then the issue is that you may have the incidence of this toxicity may increase. For all these diseases, this is general education. You have to avoid mosquitoes. Okay, this is all these mosquito-related infectious diseases. This is going to be critical. Now, there's also yellow fever. Yellow fever is in Africa and America. Yellow fever is not in Asia. There's also yellow fever in some parts of Latin America. Of course, the idea of getting yellow fever, you go to a city, is almost non-existent. Then, you go to a meeting in Rio de Janeiro, you go to a meeting in Sao Paulo, well, probably, but again, this has to be individualized, because you go to a meeting there, but then you plan to travel, to the Amazons, and, this is a different story. Okay, then we discuss the vaccine-preventable infection. Let's go to the non-vaccine preventable infectious disease that we're going to discuss in the clinic. Traveler's diarrhea, malaria, dengue, cholera, tick-borne encephalitis, and tuberculosis. Traveler's diarrhea, tap water, no. Bottled water, yes. No ice made with tap water, no raw food, rinse with tap water. This is difficult. But now it's also interesting that in plenty of these countries, there's, everybody knows that no tourist is going to, every tourist is looking for the bottled water. Okay, then there's a lot of production of bottled water locally, that is tap water, pour into a bottle, you get bottled water. And then we buy this one. Then we wonder why you get traveler's diarrhea when you travel abroad. There's a lot of this going on. Then the rule that you're going to be discussed in the clinic is this one, but at the same time, it's also so difficult to follow the rules. Because, you go to a local place, you want to test the local food, that's it. In this case, the recommendation is self-treatment. And we discussed, there is the recommendation of prophylaxis, meaning that you start taking something before going there, versus self-treatment is that you're going to get the infection, and once you get the infection, you are going to start treatment, self-treatment. Then for traveler's diarrhea, the recommendation is self-treatment. Now, the antibiotic that you're going to get in the clinic is going to be either ciprofloxacin or azithromycin to bring with you to do the self-treatment. These are going to be the organisms that you're going to get when you start taking water, and the enterotoxigenic E. coli, the other ones. There are some of these organisms in some areas that are becoming resistant to ciprofloxacin. This is why, for some particular areas, mostly Campylobacter resistant to cipro, then azithromycin may be a consideration. Of course, quinolones are contraindicated in pediatrics, then it's going to be the alternative of the macrolide. Malaria. Again, mosquitoes is critical, but here we change and we do chemoprophylaxis, at least in the United States. Okay, we are going to send you with some medication, and the issue is, and the medication, this is the cycle, and these are the 3 medications that are going to get in the clinic, either chloroquine, doxycycline, or Malarone. We know that the mosquito is going to inject the plasmodium, and then it's going to be a couple of days, the plasmodium is going to be in the liver, 10 days to 3, 4, 5 weeks. Then, and then when the parasites in the blood, the person is going to develop fevers. This is why, since this usually takes 3, 4, 5 weeks, it's very common for us, fever in the return and travel from any one of these areas for us in the clinic, malaria, until proven otherwise. And of course, going back to the issues of finances, this is very good, but it's also very expensive. Okay, then dengue. Another one that you can have just dengue fever, or you can go all the way to dengue hemorrhagic fever, you can die of dengue. In the case of dengue, this mosquito feed during the day. In the case of malaria, the mosquito feed during the night. Then if you're in the tropics, any mosquito bite, night or day, is bad news, okay? It's either dengue or malaria. Okay, then, but again, mosquito avoidance measures are going to be important. Cholera, this is an oral kill vaccine, but it's not in the United States, not FDA approved, and this would be probably indicated you go for a medical mission, some particular area of the world. And then the tick-borne encephalitis, this is an emerging viral encephalitis in Europe and Asia. And essentially this virus is transmitted by a tick bite, then similar to what the recommendations that we give here for a person to prevent, some of the tick-borne diseases. Again, the vaccine that seems to be effective is not available in the U.S., but we've been having some requests how to get this vaccine for some, which I happen to have a group here that was going to Ukraine to work with rodents in the forest area, and they were looking for the tick-borne encephalitis vaccine. Then you may, and we always investigating, trying to how to get these vaccines that are not FDA approved for some travelers at risk. Tuberculosis. There is the issue in a healthy traveler, if the person is going to go to a place, there is tuberculosis, is going to be in contact, it's going to be for some time. Well, should the person require a PPD or quantiferon before going there, and then after a couple of months when he returns, do we need a quantiferon and PPD to see there was TB infection that we need to treat, latent tuberculosis infection. And there is even the consideration that you travel with a child, since BCG vaccine is indicated in other countries where tuberculosis is prevalent to prevent TB meningitis and death in children. There is even the consideration for BCG in the pediatric international travel. Okay, then this will be for the non-vaccine preventable infections. Medical conditions. If the person has diabetes and you need to adjust your insulin, you go north, south, and you change 2-3 time zones, is not an issue with your diabetes. But if you go east and your day is going to be short, or you travel west and you're going to have a very long day, how many times you're going to eat, what are you going to do with your insulin? It's not that we're going to be adjusting the insulin. We send the patient to the endocrinologist. So we need to, you're going to have a 36-hour day. We have to take care of this. Altitude sickness, another very common. We know at sea level, 21% FiO2, PO2 150 in the air, in the alveolar 100. If this is 100% oxygen, as you move up, the oxygen go from 84, 66, and this is I mean, of course, not everybody goes to Mount Everest, but there's a lot of people that goes to areas that you can get altitude sickness. Then a lot of people are going to get the headache, the nausea, the vomiting, the malaise. And then another vignette, a group of 6 radiologists from Louisville are evaluated in the clinic, and they are going to Mount Kilimanjaro. They all were advised to take acetazolamide, that is based on the recommendations, and just one of them only decided not to take. And which one of the radiologists developed headache, nausea, and dizziness? Yes, the answer is F. Then, based on our experience-based medicine, we think that acetazolamide is very good to prevent. And we also have elderly travelers, because I understand there was Ruth, it was a 78-year-old that went also husband and wife. And with acetazolamide, they both did fine moving. And they went to?
They actually were traveling towards Mount Kilimanjaro.
Okay. Then we have a medical condition. Then some general education. And general education, I don't want to go through all this, but we discuss injury prevention, swimming safety, HIV, STD prevention, because statistics show that 20% of international travelers are going to have a new sexual partner. Then STDs are going to be important, even though we discuss that sometimes, I don't know, but sometimes I was told that no, the adolescent is there in the clinic, and someone is discussing, the adolescent is going to do the international travel, the parents are there, we are discussing the advice, and the parents are listening, and the adolescent is playing with the phone. Okay, you're discussing STD prevention, nothing is going to happen. Insurance issues, healthcare in the local country, evacuation insurance, and then bringing a dead body back to the United States is also very expensive, and it may be a consideration for insurance there. Crime prevention, because as we learn, and we also learn with the travelers that return to clinic, in particular countries, criminals has special characteristics. Then, ATM abduction, express kidnapping, taxi corruption, all these things are going on in different countries. For travel consultation, we are just, if the person is going to a particular place, we want to get in contact and be in contact with the traveler, with the local clinic, with the local hospital, and there is an email address and there is an Skype address for the traveler to be in contact with the clinic. For post-travel consultation, essentially, this will be then the person return with some problems. For us, the most common will be fever in the returning traveler. And even though the fever in the returning traveler may be something simple, may also be malaria or dengue, some life-threatening conditions. Dengue, malaria, respiratory tract infection will be the most common. Maybe diarrhea in the returning traveler or skin lesions in the returning traveler. This will be the most common scenarios. Then, physician from Louisville, his wife traveled to Central America on a mission trip. The wife developed diarrhea. She was treated locally with antibiotics, improved, returned, developed diarrhea again, was evaluated in our clinic. All the workup was negative. We thought that this was giardiasis that we cannot find. We treated empirically. She persisted with intermittent abdominal pain, bloating, diarrhea on and off. After full workup negative and things continue the same, then she had the diagnosis of post-infectious irritable bowel syndrome, that we know that this can happen 5 to 10% after you develop traveler's diarrhea. And this is an issue, it's still unclear, probably some cytokine, local response, alteration in fecal flora, but the idea is that this is what this person developed. Another thing in the returning traveler is the returning traveler may have an infection that then is going to spread locally. And the infection that can spread locally are going to be measles, severe respiratory distress syndrome, and these coronaviruses that emerge on and off in different parts. And we know that the severe respiratory distress syndrome, this was for the avian influenza, These two are the ones that the person who has pneumonia get admitted to the hospital, and then for the first time we have pneumonias that get transmitted to the nurse, to the treating physician, and then the healthcare worker dies. Because this is new. I mean, we all treat severe pneumonia, but we never die of something that we get from the person with severe pneumonia. Then there is the possibility of sexually transmitted disease, multi-resistant gonorrhea, of HIV, multi-drug-resistant tuberculosis, and then multi-drug-resistant bacteria. We all know the story of the New Delhi beta-lactamase that was really identifying returning travelers to England, and multiple of resistant bacteria. Then, pneumonia in the returning traveler. He's a 52-year-old physician from Kentucky. He developed cough, shortness of breath after returning from international travel. The patient called the clinic to be evaluated for the last 5 days. He had fever, progressive shortness of breath. It's interesting. The partner is telling us that in between patients, he has to use oxygen, a mask, because he was so short of breath. He continued working. Typical to a physician. Continue working until the end. Then interstitial bilateral infiltrates. Okay, these are the characteristics of the traveler. What are the characteristics of the trip? Then let me go back and tell you that this occurred during the outbreaks of severe respiratory distress syndrome that happened in China and Hong Kong, and this was at the time that healthcare workers were dying in the hospitals, and this was at the time that the first case happened in Canada from one person. The outbreak in Canada was one person from Hong Kong traveled to Toronto. And after this person arrived with SARS, SARS spread in Canada. Okay, what was the itinerary? He returned from China in March 2003, and he was there for 2 weeks. And the most interesting thing, what was the activities? Okay, you can guess. What were the activities? Yes, he was interested in healthcare, and he was 2 weeks trips visiting hospitals in China. He was mostly in hospitals. Then at that point, I was working with Ruth Carrico, and when she was the director of infection control here at the hospital, and we said, well, we were convinced that we had the first case of SARS in the United States. Well, we know that there was no case of SARS in the United States. This was not the case, but we were convinced at this moment. Then we made arrangements to have direct admission to University Hospital respiratory isolation. The issue was, how do we transfer this person from this town in Kentucky to Louisville? What happened with the ambulance? What happened with the isolation? Whether we want to put the patient here? We discussed with the ER to get into the respiratory isolation room in the ER. We checked the batteries of our poppers. We tested. Everything is fine for us to use full respiratory protection. And then we are waiting for the person to arrive. When we get, I got a call from admission office that he had drove here, and he was sitting there to be admitted. And then I got a call for Ruth, said the physician was coming, and you mentioned was coming with a surgical mask. The surgical mask and the luggage. Just, where's my room? Then what we learned is that essentially, if you plan to prepare for an outbreak containment, Murphy's Law, it will always apply, okay? Then regardless of what we think that we're going to be ready, but everything is going to go wrong. Then this person who had positive serology for Coxiella burnetii, he acquired Q fever in China. Okay, and to finish, I mentioned that this travel medicine is in the 550 clinic. We changed the name of the clinic. As a matter of fact, this was something that originally came from our patients, our consumers in the clinic that wanted to have a more like a multidisciplinary clinic, a different type of clinic, and we said, well, this is going to be perfect. We're planning to expand to travel medicine and other things. Then, what do we have now in the 550 clinic? We have the vaccine and this is in the second floor of the ACV. The vaccine and travel medicine, we have all our comprehensive HIV medicine, with social workers, pharmacists. I mean, this is a lot of group working there with our HIV population. We are expanding our telemedicine, and then we have the refugee health that is also connected to our vaccines and travel medicine. Then we have multidisciplinary services. If you come to the clinic, who are you going to see? one of members of the team that are here. Then it's going to be it's going to be Ruth that's been instrumental it's has been Ruth Carrico and Paul McKinney and myself. We were the three that moving working on this clinic, and Paul is still helping us with advice. Kelly, that's going to be most of the research that's happening in the clinic. Don, that is going to be also seeing patients. And then Dr. Pirani, Dr. Rauron, Paula, and Anu, that are also coordinating our HIV programs and whatever is going on in the clinic. Of course, that this is a very large group of people working in the 550 clinic. And then you come to the clinic, then we are going to have this is going to be the computer, the TV. We are going to discuss the different countries as you travel. We are going to try to convince you to get all these vaccines. And then the idea of, just briefly to mention that we are working with refugee health. And refugee health is another multidisciplinary approach. This is there's a lot of students working on refugee health. This is a lot of vaccine preparation, Dawn and Ruth explaining, and there's a lot of vaccine administration that's going on with refugee health. And the program is not too old, but I was told yesterday that we have more than 2,500 vaccinations that already occur. And the only way to do this is thanks to the mostly with Ruth, but all the partnerships that we have with different nursing students and pharmacy students and faculties. And also pleased to know that even in our Department of Medicine, we are developing the idea of refugee health. We are expanding on this. Then essentially, where do we move from here? The multidisciplinary surveys are moving into more like a global health that we do in service, patient care, teaching, research. The vaccine and travel clinic, the number of is not patient, but the number of clients, because you're not a patient when you're going to travel international, but the number of clients keep increasing and increasing. In HIV medicine, as you know, the epidemic is full steam here in Kentucky. Then this idea that the epidemic is under control is not here. We have new patients every day. I want to take parentheses 1 minute to say that what is the CDC recommendation to get HIV testing? Any person that is in contact with healthcare. You don't need to wait for, look at this funny infection. Could the person have HIV? Any person that we have in contact in the hospital and the clinic should have HIV testing. Whereas every week we have new cases, and the problem is that the new cases are still with advanced HIV disease, very low CD4, and the problem is also these always new cases, some females that the risk factors are 0. Okay, they just happen to have the infection because the partner was having the risk factors. Then it's very important to have a testing. Again, we are seeing more and more of these patients. The telemedicine is expanding, and the refugee health is also, we get more and more refugees in Louisville. Then the 550 clinic is already too small for us, and we're already discussing where we move. And the goal of the group is probably to go from the 550 clinic to the 550 home. Okay. Then I want to finish saying that we're looking for donors that would like to move our global health out of the ACB building into a place that our consumers can stop by, have a coffee, or have some discussion of all these different issues. This is in the plan. Then essentially, I briefly discussed the principles of travel medicine. This is a new subspecialty in infectious diseases, and we already convinced Dr. Rauran that is going to be our specialist, because she's going to take the certification for travel medicine later on this year. Pre-travel consultation, that as you see, there's a lot to discuss. This is why this pre-travel consultation usually takes 45 minutes to have one person or the family. The travel consultation, we want to keep in contact with the travelers. Post-travel, that we know that is common to have medical issues after returning, and here is where malaria and dengue and is always a consideration. And then the 550 clinic, this new idea that we have in the division, mostly moving into global health. With this, thank you very much for your attention.
I'm sure that Dr. Ramirez would be happy to address any questions that you have.
Dr. Ramirez, I had a question about the post-infectious and irritable bowel syndrome. We see a lot of that in primary care. People who were treated maybe with 3 days of antibiotics come back, have persistent symptoms or new symptoms, and you worry, do they have C. diff, but they don't. What's the natural history of that? How long does it last, and what should we tell our patients about it?
When I reviewed the data for these patients, it's similar. We have a pattern of stories that we have in infectious disease, similar when you have the chronic fatigue syndrome, and this they will say, well, you're not going to die of this. We don't know what is the cause of this, and most of the patients recover, but we don't know when. Then it's not a very. But to me, what is probably important for these things is just to have a diagnosis. And then usually we send the patients to you guys to figure out what happened with the diet and whatever. Because, but yes, it's unclear. It's interesting because as there's more and more international travel, more and more travelers diarrhea, and this is 5 to 10%, this is becoming a serious issue for all the travelers. I hope there's going to be more research, but I didn't follow. After this patient, I didn't follow what happened in the literature with this. I don't know.
Are there any other questions?
There are several masks available for air travelers to prevent upper respiratory infections. How effective are they?
What are the mechanisms? Say what is?
The mask.
Oh, the mask. This is the issue of the mask. If you go to an area where there is, well, first of all, let me also mention that the primary way of transmission of most viral respiratory diseases are the hands. Then we go back to the idea of hand washing. That is critical. Then because of influenza and all these the respiratory viruses, the idea is that the person is coughing, and you have a respiratory virus, you're going to have it in your hands, then you give the hands to the other person, then you touch yourself. This is the most common way of transmission. Then hand washing is going to be probably critical. Infectious diseases that are transmitted through the air, the classical would be tuberculosis. But there are not too many pneumonias that are transmitted through the air. Most of the pneumonias, you just touch, put it on your oropharynx, from the oropharynx microaspiration. There is a consideration for Legionella, but Legionella will not be person to person. It's the air conditioner to you. Then the only one that is air and is person to person would be tuberculosis. Someone is coughing, it's in the air. Then I may say that you go to a particular, but this will be, you're in a hospital setting that you have to be in.
But air travel with the recirculated air, there are studies that 10% of the travelers get respiratory infections.
Well, I mean, this has always been studied. If there's a person with tuberculosis in a plane, everybody's in trouble. The person is coughing because the air. Now there are other issues with air travel is that because of the changes in pressure and because of obstruction of the Eustachian tube and the nasal canal, then people are more predisposed to respiratory conditions, and then you have all these allergies. Then how much of these are viral infection, how much of this is the travel itself is unclear.
So you wouldn't recommend to wear masks if you go on a long trip?
No, we don't.
Any other questions? Well, if not, thank you so much.
Thank you. Oh,